Good morning. I have this TOG article which is titled as Diabetes Insipidus in Pregnancy summarized for you to help with your revision of your MRCOG exams. I hope you'll find this video useful. Don't forget to give it a thumbs up and also subscribe to the channel if you haven't already. So diabetes insipidus is a condition where you have a failure of the renal tubules to conserve water. Symptoms are of polydipsia, polyuria, hypernatremic dehydration with neurological sequelae such as weakness, confusion, and seizures. It's there's 2 to 4 per 100,000 pregnant women. Diabetes insipidus in pregnancy is a self-limiting condition. It usually arises in the third trimester and remits spontaneously 4 to 6 weeks postpartum. So the physiology, the normal physiology is you have ADMH, which is a vasopressin. It's antidiuretic hormone. It's secreted by the posterior pituitary. It has effects on receptors V1 and V2. The Once it's secreted in response to increased plasma osmolality, which is detected by the hypothalamic osmoreceptors, by reduced blood pressure detected by arterial baroreceptors, and also it's also released in response to decreased renal perfusion via the renin-angiotensin system. ADH acts at the kidneys by stimulating the V2 receptors. It causes insertion of these water permeable protein channels known as aquaporins, specifically aquaporin 2, into the apical cell membrane of the collecting ducts. This then allows the reabsorption of water and hence results in concentrated urine. The cardiovascular effects of ADH are minimal. However, in high concentrations, ADH acts at the V1 receptor in the vascular smooth muscle to induce systemic vasoconstriction, physiological response to which responds to hypervolemia. V1 receptors are expressed in high densities in the vasculature of the renal medulla, moderating medullary blood flow. ADH is also involved in platelet aggregation mediated via V1 receptor. The oxytocin and the vasopressin receptors have similar structure. So oxytocin receptors have equal affinity for oxytocin and ADH. V1 receptors have 30-fold higher affinity for ADH than for oxytocin. Secretion of ADH therefore activates oxytocin receptors, and high doses of oxytocin have the potential to induce physiological action of ADH. So physiology in pregnancy, so there is decreased in systemic vascular resistance early in the first trimester and continues to decrease until the middle of the second trimester to about 60 to 65% of baseline. There's also increase in cardiac output. However, there is insufficient, this is insufficient to compensate fully for the decreased systemic vascular resistance. Blood pressure therefore declines in the first trimester, and this non-osmotic stimulation lowers the threshold for ADH release. Consequently, there is increased aquaporin insertion in the collecting ducts. This mechanism, along with increased thirst and hence water intake induced by the activity of relaxin, leads to hyponatremic hypervolemia of pregnancy. Vasopressinase is released from the placenta. It's in increasing amounts until term. It metabolizes ADH. Vasopressinase mediated degradation resists the increased release of ADH in the pregnant female. ADH secretion consequently increases, fourfold increase in ADH secretion by the third trimester. The vasopressinase is metabolized by the liver. Mechanism for association of gestational diabetes insipidus with preeclampsia and HELP syndrome. Other causes of liver dysfunction can also interfere with vasopressinase metabolism and contribute to diabetes insipidus. For example, hemochromatosis induced liver dysfunction. Diabetes insipidus may also occur with where hepatic metabolism of vasopressinase is unimpaired, but compensatory increase in synthesis and release of ADH does not occur. The vasopressinase secretion is increased also in multiple pregnancy, and a polyuric state is more commonly observed. So pathophysiology of diabetes insipidus, so there is three types: the neurogenic, the nephrogenic, and gestational diabetes insipidus. So neurogenic is centrally induced. It's the commonest form of diabetes insipidus in the non-pregnant patient. It's caused by inadequate synthesis in hypothalamus or release of ADH from the posterior pituitary. Causes include a trauma, neurosurgery where there's damage to the hypothalamus or the posterior pituitary. Rarely it damages the hypothalamic neurohypophyseal pathway, such as stalkitis. Nephrogenic diabetes insipidus occurs because of renal insensitivity to ADH, and in adults, this can be acquired as a result of renal failure. Gestational diabetes insipidus results is a metabolism of ADH by the placental enzyme vasopressinase. Vasopressinase levels are higher in multiple pregnancies as vasopressinase is metabolized by liver. Any hepatic impairment, like for example in preeclampsia, in HELP syndrome, tends to exacerbate the symptoms. So primary polydipsia is a result of excess fluid intake with normal pituitary and renal function. In diabetes insipidus, classically it presents with polydipsia and dilute polyuria. It's a diagnosis of exclusion after other causes of polydipsia and are excluded, like diuretics, hyperglycemia, hypercalcemia, hypokalemia, and renal tubular acidosis. So water deprivation test can be done to help diagnose this condition. However, this is not carried out in the pregnancy because of risk of harm from dehydration. So this test involves fluid restricting for several hours to assess whether this leads to an appropriate urine concentration. So thorough history to elicit symptoms of polydipsia and polyuria are required in pregnancy, as you cannot do this test. In non-pregnant patient, normal plasma osmolality is 285 to 295 milliosmoles per kilogram. And osmolality of the urine can be up to double this value. In pregnancy, normal plasma osmolality is reduced to approximately 270 milliosmoles per kilogram, and serum sodium levels are also reduced from normal by 4 to 5 millimoles per liter. In gestational diabetes insipidus, this should be considered when blood osmolality is consistent with non-pregnant values. Um, Gestational diabetes insipidus may also have borderline high serum sodium that may be within normal laboratory limits but is elevated compared to normal pregnancy levels. Urine to plasma osmolality ratio outside of pregnancy is used to exclude significant diabetes insipidus. If the urine to plasma ratio is more than 2:1 and plasma osmolality is no greater than 295 milliosmoles per kilogram, then significant diabetes insipidus is excluded. In diabetes insipidus, urine will be dilute with a urine plasma ratio of less than 2. Um, ADH levels can also be assayed with a vasopressinase inhibitor to determine whether levels are low because of a centrally caused lack of production, or as a consequence of degradation from the placental produced vasopressinase. Chromatography can also be used to measure vasopressinase activity. The vasopressin treatment differentiates between different types of diabetes insipidus. A central and gestational diabetes insipidus results from a lack of circulating ADH. Vasopressin therapy can lead to improved biochemical and physiological parameters. However, it will have no effect on nephrogenic diabetes insipidus because ADH production and circulation is already adequate. It's a receptor that is unresponsive to the hormone in nephrogenic diabetes insipidus. So the pituitary function tests like thyroid function test and prolactin to look for panhypopituitarism that can occur as a result of large tumors or Sheehan syndrome. If patient has headaches or visual field defects such as biotemporal hemianopia, then a MRI scan should be done to rule out a tumor. So prenatal and antenatal management. So pregnant women are diagnosed with diabetes insipidus based on clinical features and investigations, and they should commence treatment after diagnosis. Their symptoms should be regularly and clinically reviewed during antenatal appointments, including serum electrolytes. Um, to check they're not dehydrated. Desmopressin is the treatment of choice. It's an ADH analog and treatment for neurogenic and gestational diabetes insipidus. It's a synthetic form of ADH, basically that renders it immune to metabolism from vasopressinase. It can be administered orally, sublingually, intranasally, subcutaneous, intramuscular, or as IV injection. It's safe throughout pregnancy and breastfeeding with no known adverse effects upon delivery of the neonate. In neurogenic diabetes insipidus, the desmopressin dose should be increased during pregnancy and reduced postpartum. As vasopressinase is metabolized by the liver, high concentrations are seen with hepatic dysfunction, hence the need to exclude preeclampsia, HELP syndrome, and acute fatty liver of pregnancy in new onset of diabetes insipidus in pregnancy. In nephrogenic diabetes insipidus, treatment correcting hypercalcemia and hypokalemia and use of thiazide diuretics. Within pregnancy, thiazide diuretics is contraindicated due to effects on the fetus. So, intrapartum and postpartum, the dose of desmopressin is 1 to 4 micrograms daily. Monitor signs of hypernatremia like weakness, altered mental status, seizures, and a coma. Um, if hypertonicity is corrected too rapidly, serum osmolality can be relatively hypotonic compared with brain cells. This can result in damage to the central nervous system secondary to brain cell swelling. So the serum sodium levels should be corrected slowly and no quicker than 1 millimoles per liter per hour. Following delivery, management should be in a critical care setting to allow close monitoring, continued fluid resuscitation, and correction of any abnormal electrolyte levels. Definitive management of gestational diabetes insipidus involves delivery of placenta. And normally, symptoms and biochemical abnormalities spontaneously resolve postpartum. So in operative delivery, there is a reduced intravascular volume that can render a spinal anesthetic inappropriate. Hypernatremia may decrease potency of local anesthetics. This is especially important for epidurals, for example. The patient should be referred for antenatal anesthetic review, and the on-call anesthetist should be informed when the patient is admitted to labor ward. Preeclampsia and HELP syndrome impairs metabolism of vasopressinase by liver. Increased circulating levels of vasopressinase results in reduction of ADH. MRI angio revealed that vasopastic consequences of preeclampsia and HELP syndrome can lead to reversible cerebral vasoconstriction syndrome. This may lead to decreased ADH release from the posterior pituitary. As a result, there's not only increased degradation of ADH, but also a reduction in the amount of ADH released. MRI scan for gestational diabetes demonstrates and for gestational diabetes insipidus demonstrates an enlarged posterior pituitary with absence of normal physiological hyperintense signal. These changes resolve on postpartum rescanning. Excessive vasopressinase activity leads to low ADH levels and depletion of ADH stores. As stores are replenished postpartum, normal appearances return. Diabetes insipidus adverse effects on prophylactic treatment of eclamptic seizures. So magnesium sulfate is renally excreted with half-life of 4 hours. The GFR affects the excretion rate and therefore the drug's half-life. Increase in GFR can lead to the drug being more excreted more rapidly with a reduced half-life. So in patients with preeclampsia with coexisting diabetes insipidus, it's important to increase the magnesium infusion rate and also combine this with magnesium level monitoring as there is more of this drug that's excreted. Patients with preeclampsia and coexisting diabetes insipidus can prove to have a challenge with their fluid management as there is volume depleted state because of diabetes insipidus with a need of judicious fluid management as a consequence of preeclampsia. So an MDT approach with senior obstetric and anesthetic staff should be taken to care for the patient, which involves invasive monitoring and close clinical observation. Effects of pregnancy on diabetes insipidus. 50% of women with pre-existing diabetes insipidus will deteriorate in pregnancy and improve following delivery. Pregnancy can unmask subclinical diabetes insipidus that preceded pregnancy because of degrading of placental vasopressinase. Consequences of diabetes insipidus for the fetus. No adverse effects have been are seen in pregnancy. However, some reports have shown severe dehydration, metabolic acidosis, maternal rhabdomyolysis, hypernatremia, and severe polyhydramnios. So, consequences of diabetes insipidus for the mother during pregnancy. The prompt diagnosis and effective management means that morbidity and mortality are low. However, if it's untreated, it can lead to potentially life-threatening consequences. So, classification of diabetes insipidus, we've already gone through this, but I'll let you look over this, especially the different causes. Summary of clinical features and suggested investigations. We've also looked at this. So you can also have a look through. So presenting symptoms of polyuria greater than 3 liters a day, polydipsia greater than 3 liters a day as well. Investigations including urea electrolytes, calcium, glucose, serum plasma osmolality, urine osmolality, and urine specific gravity. So doses of desmopressin, so as we've seen, it can be given orally, sublingually, intranasal, intravenous, intramuscular, subcutaneous injection, and the various doses are also tabulated. Well, that's it. I hope you found this summary useful. I remember when I was revising for my exam, I found this TOG article quite difficult to understand and also to also comprehend everything that it was trying to tell us, and which is why I thought it's important that I summarize this for you so that you are able to follow it and understand all the important points around this. I hope you found this useful. Don't forget to give this video a thumbs up and subscribe to my channel if you haven't already.